Hello, I am David Kunkel from the University of California, San Diego, and I'm joined by a couple of outstanding colleagues today. We're going to be talking about amyloidosis of the gastrointestinal tract. So I'm going to introduce our first guest, Lucy Harris from Mayo Clinic, Arizona. Lucy, how are you doing?
Good, thank you. Thank you for inviting me to do this.
And Ali Rezaie is also joining us. Dr. Rezaie is based out of Cedars-Sinai in Los Angeles. Hey, Ali.
Thanks for having me.
Good to be with both of you. So what is amyloidosis? Why does it matter? Why is it of interest for gastroenterologists such as ourselves who are motility providers? I'll provide a little bit of background info and then we'll sort of dive into that topic. Amyloidosis is a problem in the body where misfolded proteins get spattered around different organs like graffiti. And so this can hit the heart, it can hit the nerves, it can hit the kidneys, it can also affect the liver and anywhere in the digestive tract. When it lands, it can affect organ function. And so that gives rise to symptoms and problems. There are multiple types of amyloidosis: tissue transthyretin, TTR amyloidosis, which can be inherited or develop with age over time. There's AL amyloidosis, and there are other rare types. Ali, when you hear about amyloidosis, what comes to mind from a GI perspective?
First off, I love your graffiti sort of analogy. I love it. I'm going to use that for patients and also to teach fellows, because that's actually really good, because that's actually one main point about this. It's very patchy. And it's very erratic. It can hit your heart. It can hit your GI tract in a very different ways, right? So it can affect stomach. It can affect small bowel. It can affect the colon. And depending on where it affects and how it affects it, the symptoms are different. So if it affects the stomach, obviously, it can cause gastroparesis, right? So the patient can present with nausea and vomiting. It affects the small bowel. It can present itself with dysmotility of the small bowel and malnutrition. And if it affects the colon, then the same story. It can present itself with constipation, sometimes diarrhea, and a lot of different symptoms. And in end stages, as we were talking before this podcast, it can start to ulcerate the bowel, and GI bleeding can happen. So a variety of presentations that we see almost every day in clinical practice in GI. So this has to be one of the differential diagnoses that should be on our list for a lot of cases.
I think another helpful way to look at it, as you were referring to it, is that there is primary amyloidosis and the secondary amyloidosis, which we run into particularly as gastroenterologists in our inflammatory bowel disease patients. So I think that's a good thing. And then there is the isolated type. So if I could maybe share a story, I think one of the reasons that I always keep it in mind, and this is a story of isolated amyloidosis, was that my grandmother was treated at Harvard at Mass General for isolated amyloidosis that involved only her trachea, and she made the medical literature. And this was about 60 years ago now, where she actually had tissue from her thigh transplanted to be an artificial trachea. And because of the work that they did, she lived to age 87, and she had no recurrence until very late in life.
Wow.
You know, it's a personal story, but I think, it brings to mind that it can occur in a variety of different places.
That's an incredible story, and so it shows that this is sort of like a masquerader. It takes on a lot of different forms, but amyloidosis can injure where it lands, and it can lead to organ dysfunction. Like with your grandmother, it affected her windpipe. It affected her ability to move air and control air. And so, thank you for sharing that, Lucy. What are clinically, we see patients who have all kinds of symptoms. What are some of the symptoms that are more suggestive that amyloid might be present in the gut? What comes to mind for you?
Well, I think, we deal as gastroenterologists very commonly with patients who come in with diarrhea, and we think about ruling out inflammatory bowel disease, and I think we're better now at ruling out celiac disease. But I think it should pass our mind, particularly in middle-aged to older patients. And I believe it's a little bit more common in men. But if they're having a refractory diarrhea, we can add it to our panel of what we ask for when we are doing especially small bowel and colon biopsies. We can ask for a Congo red stain. It's not that costly, and it might pick up somebody who we didn't, especially if they also have weight loss. These are all things to think of. We should do Congo red stains on those patients. Ask for that from our pathologists.
Okay, yeah. So Congo red staining is an additional step that can be taken with biopsies, samples from the lining of the digestive tract, and it lights up that amyloid like a Christmas tree. So, Allie, this is a disease that can affect different organs. If you are seeing a patient who has known amyloidosis, maybe a cardiologist has referred this patient to you and they're having GI symptoms, can you walk us through how you approach that patient?
Absolutely. By the way, that is becoming a more common scenario as well because of very specialized scintigraphy of the heart that they do, and they can specifically see findings of the amyloid in the heart. And now there are capabilities of biopsying the heart, right? So, and they do that, which is all new stuff. And when I was training, this weren't a thing. So, so when I see those patients, definitely I do an EGD and colonoscopy and do a detailed biopsy of the. I do esophagus, stomach. I almost map the stomach, and also duodenum. And I usually try to go a little bit deeper into D4 and biopsy there as well, as deep as I can, because as we discussed, it can be patchy. And then on the colonoscopy, biopsying, mapping the whole colon, and preferably biopsying the terminal ileum. But the most important thing, tell the pathologist, don't just write diarrhea. Tell the pathologist that this patient has amyloidosis, or you're suspecting amyloidosis, so they look for those findings, right? Because usually they focus on the cells, they look at the mucosa, but looking at the deposits, you have to switch your brain a little bit to look at those deposits. With H&E stain, it's not easy to see. The good pathologist sees them, and then they do Congo red stain. So now, depending on what other symptoms patient has, this patient has bloating and diarrhea, I do a breath test too to rule out bacterial overgrowth. And if they have a nausea, vomiting, I check for transit studies, for example, gastric emptying study as well. We're lucky to have a nutrition program as well. So if patient has malnutrition, obviously I get them involved as well. But maybe we ask Lucy about
that. So I was going to add, when you're doing a diarrhea workup, I think it's especially when you're seeing profuse diarrhea, which amyloid can cause, they're like the celiac patients. You should check iron stores, B12, folate, trace minerals like copper, selenium, and zinc. I think those are all important studies to get when you see profuse diarrhea with weight loss, particularly.
That's really helpful. And just like with your grandma, where the amyloid was affecting her trachea, and so there was dysfunction in that organ. Allie, you've talked about how if it's in the stomach, that can lead to impaired transit in the stomach or gastroparesis. You also mentioned small intestinal bacterial overgrowth. Can you elaborate a little bit on how amyloidosis could lead to overgrowth and what is overgrowth?
Yeah, absolutely. Overgrowth is essentially when coliform bacteria in the small bowel are overgrown beyond what they usually should be, less than 1,000 bacteria. Now they're growing more. That's whenever there is this motility, there is dysbiosis, right? Mm-hmm. And amyloidosis is not an exception. So when the small bowel is not moving well, now because of everything, in this scenario, because of the deposits that can be around the nerves, interstitial cells of Cajal, or enteric nervous system, or it can be deposits so dense that it can even stiffen the wall. So in that scenario, small bowel is not moving. So the bacteria in the colon that creep back up into small bowel can't be pushed back where they are. So the bacteria starts to overgrow. And this presents itself with patient eating and getting postprandial bloating, and also causing diarrhea, changing bowel habits, and in end stage is malnutrition. So that's one thing that needs to be ruled out with somebody with known amyloidosis.
Amyloidosis deposits in the blood vessels. Have you had experience with bleeding or issues related to bleeding from amyloidosis, Lucy?
Yes, I unfortunately have. Until recently, there weren't treatments for amyloidosis, and even those treatments, unfortunately, patients do sometimes reach an end stage, and it can cause very refractory bleeding where just even touching the mucosa starts an area bleeding. And I think Dr. Rezaie referred to ulcerations that can also occur. So it can be a very overwhelming disease and sometimes even a cause of death, unfortunately.
So you mentioned there are new treatments for amyloidosis, and, indeed we're in this new era. When all three of us were in training, amyloidosis was a fire that couldn't be put out, and we were left sort of trying to manage the smoke. Now we're in this new era with multiple new treatments for both ATTR amyloidosis as well as AL amyloidosis that can put a stop to new misfolded proteins being spun out. Allie, in this new era of treatment, does it matter time to diagnosis? Does that have implications for preserving tissue and organ function?
Oh, absolutely. It's very important to be vigilant about this disease and diagnose it, because there are very potent treatments and very effective treatments available. And more importantly, the earlier the disease is diagnosed, they work better. I'm going to... for example, for AA amyloidosis, which is inflammation induced, so when you diagnose that, the treatment is suppression of the inflammation. And if you think about diseases that are associated with this, rheumatoid arthritis, IBD, the management of those diseases have been revolutionized, right? So we have so many treatments to push these patients into deep remission. So that's very important. That's for AA. For AL, obviously, the management of multiple myeloma in the last 10 years just completely got revolutionized. So targeting that is very important. So don't forget about doing your SPEP and UPEP in your cases with malnutrition and profuse diarrhea that you're like, okay, something is off. And regarding TTR, first of all, we have now genetic testing to exactly say that, okay, they have a hereditary ATTR. But now there are treatments that you can do the gene silencing, or you can just suppress the production of these proteins and these misfolded proteins, and are very effective. I'll give you one example. It was very common to see with end-stage cases of amyloidosis, to see with ATTR, to see liver transplantation, because that's essentially where it's produced. And we would do liver transplantation. I haven't seen a single case of liver transplantation in the last 5 years. This is how effective these medications are in suppressing a production of amyloid deposits.
Wow.
Right. And I think, Ali, you point to another sort of trend in medicine. I think that we've all tried to become more cost effective in our workups, but then we also have to be selective because there's less routine testing of urine analysis or blood work. So I think we even have to be more vigilant and pay more attention to actually thinking about these things when we're seeing patients who don't, especially when they don't fit the initial paradigm that we think their diarrhea is due to.
Yeah,
so
absolutely.
Think outside the box. I think that's the take-home message.
So what I'm hearing, for gastroenterologists is maintain a low threshold to request Congo red staining when biopsying the gut in a patient with unexplained symptoms, diarrhea, malnutrition, that sort of scenario. That's sort of a low barrier way to test for amyloidosis, but also look in labs, look for protein in the urine, and maintain that sort of curiosity for these sort of systemic conditions that could be driving things. What about for, just members of the general public? Healthcare is so daunting. How should you ask about amyloidosis, or what's a reasonable way to inquire with your healthcare provider whether that's something that could be at play?
That's a kind of more challenging question. I think, as I alluded to, we're just getting to the point where patients have been asking about celiac disease and trying a gluten-free diet. Yeah. I gather if they're not getting answers, if, the first pass hasn't given them an answer to their questions, I think it's reasonable, particularly if they're avid signs of malabsorption and diarrhea, to ask the doctor, can we think about amyloid?
I think that's a really good answer, Lucy. Yeah. It's so hard to lose weight without trying.
Right.
And if you're losing weight without trying and you're having loose stools, that's not in your head, and that's something you should seek medical attention for. That's a really smart answer. Ali, at Cedars, are you working in an interdisciplinary team? Do you have hematologists, oncologists, cardiologists, hepatologists, nephrologists, neurologists who you work with for amyloidosis, since this spans across all these organ systems, or how do you handle that?
Yeah, I mean, there's no question that you need a multidisciplinary team to manage amyloidosis, considering that how many organs it can affect. Definitely cardiologists, because, heart is a very common area to be affected by amyloid. Neurologists, as peripheral nerve system can easily be affected, and a lot of non-specific symptoms. Kidneys, as you said, nephrologists, and also hematologists, especially with the AL and also ATTR sort of forms. These are keys. And gastroenterologists if the gut is involved. So it's actually a fun field to be in because it's very fast moving, and also the team, and it's not just for us. Even cardiologists and nephrologists and neurologists are catching up with this whole new thing. It's not that they're super up to date and we gastroenterologists are not. This is new for everybody. So it's very important. It's very important.
At Mayo, we have a very active program, particularly for patients with multiple myeloma and amyloidosis. And so I think we're all keyed into, trying to make that diagnosis and treating patients afterwards. And really, I have to say, with the treatments, I've seen patients go from having profuse watery diarrhea to being normal and not having to worry about that. So it's really encouraging, and I think we need to be thankful for all these companies that are doing the research, these days. So
that's well said. So, I think sort of in conclusion, if I were to sort of summarize, we're in this new era of amyloidosis treatment, and we've talked a little bit about how the gut can be involved with amyloidosis and how every patient is different, and it depends on which organs are impacted by amyloid and how long the amyloid has been there, how much has deposited it. In this new era, though, time matters. The quicker we can diagnose it, the sooner we can stop disease progression. And we've talked about signs and symptoms of the disease, both from a provider lens as well as from a patient's lens. So thank you, Ali. Thank you, Lucy, for joining us today. And we look forward to making continued progress on this important disease topic. Thanks.